Hello, I'm urologist Omar Erdamakaya. Today I will have a short video presentation to share some valuable insights on testosterone management, treatment, and the associated benefits and drawbacks for individuals over 40 years of age. As we age, we tend to notice changes in our bodies, and by the time we reach 35, these changes may become more pronounced. When they reach the age of 45, the prostate begins to grow slowly. At the age of 45, the prostate may start to enlarge gradually, and by the time we reach 50, we reach the maximum age limit for prostate cancer screening. Previously, testosterone was considered a risky hormone due to its association with prostate enlargement and cancer and was avoided. However, recent research and advancements have indicated that the benefits of testosterone treatment far outweigh the risks in several areas. Currently, testosterone is widely used in various medical fields to treat patients. This hormone has been found to be effective in enhancing insulin resistance, managing obesity, improving muscle and bone tissue, and positively impacting mental and psychological states. Testosterone deficiency has been linked to an increased risk of cardiac problems, as reported in numerous publications. This raises the question of what factors should be taken into consideration when administering testosterone therapy. What level of testosterone is considered ideal for patients? When a patient presents with sexual complaints and fatigue, and their testosterone level is below 300 to 350 nanograms per deciliter, they are typically diagnosed with hypogonadism or testosterone deficiency. However, the interpretation of lab results can be a bit tricky. For example, a patient may have a testosterone level of 225 ng/dL and their lab results may show a normal range of 175 to 800 nanograms per deciliter. Does this mean that the patient is within a normal range? In fact, according to the reference values of the patients, 90% of them have normal testosterone levels. But it is low in 90% of patients according to the optimal level of 600 nanograms per deciliter. When it is between 300 and 600 that we call suboptimal levels, these patients are also likely to benefit from treatment. This is of course a separate issue, a topic for discussion. The management of testosterone levels in the blood is a complex topic with varying clinical treatment approaches, and there is not yet a consensus on established guidelines. Unlike conditions such as hypertension or diabetes, which have clear diagnostic thresholds, there is not a definitive testosterone level that indicates a need for treatment. In cases where blood pressure is 15 to 9, we can confidently diagnose the person with hypertension, and when blood sugar is 150, we can diagnose diabetes and begin medical treatment, even if the patient is not experiencing any symptoms. The reason we start treatment in these cases is to mitigate future health risks associated with these conditions. For hypertension, this includes kidney failure, eye problems, vascular issues, and heart problems. So, won't the patient suffer from any consequences of low testosterone in the future? Will osteoporosis not occur? Won't the risks related to the heart increase? Will the patient's obesity and insulin resistance not increase? Currently, clinical guidelines on this are not well established and developed. I think these will also develop in the future. So, do we start testosterone therapy in every patient with low testosterone? No. First of all, it is necessary to evaluate the patient. What is the patient doing in order not to produce testosterone? How does he prevent testosterone from increasing? In fact, we can increase testosterone in many patients, even with recommendations. Indeed, there are many factors that can have a negative impact on testosterone levels in the body. For instance, a sedentary lifestyle, unhealthy eating habits, lack of quality sleep, and exposure to endocrine-disrupting substances or heavy metals are some of the known factors that can contribute to decreased testosterone production. In addition to lifestyle factors, the patient's overall health and nutritional status can also have an impact on testosterone levels. For instance, chronic diseases can lead to a decrease in testosterone production. Similarly, vitamin deficiencies, particularly deficiencies in vitamin D, selenium, and zinc, which are essential trace elements, can also cause a reduction in testosterone levels. We can start non-testosterone, testosterone-enhancing medical treatments for the patient. And also, we can add herbal treatment. It is our goal to avoid providing testosterone to the patient since it is a long-term treatment that requires constant use, similar to diabetes or hypertension medication. This obligation to testosterone can hinder the natural function of the testicles, leading to possible shrinkage or difficulty restoring them for patients who have been taking testosterone for an extended period. Therefore, we consider using testosterone as a final resort. But what are the urological risks that patients may face when taking testosterone? What are the most feared things? There is often concern about the potential risks associated with testosterone therapy, and one of the most feared risks is prostate cancer. However, numerous studies have shown that testosterone itself does not cause prostate cancer. Rather, there is a possibility that existing, but hidden or dormant, prostate cancer tissue could grow more rapidly with testosterone therapy. To mitigate this risk, patients are screened for prostate cancer before starting testosterone therapy. As patients age, it becomes increasingly important to involve a urologist in the treatment plan. Just like prostate enlargement. When testosterone is given, the patient's prostate grows to a certain extent. The prostate grows for around 3 to 6 months. Later, the prostate remains the same size. Even if you continue to give testosterone, the patient's prostate does not respond anymore and does not grow. This is also done under the control of urology. These two problems are completely resolved under the control of urology. In addition to these two, patients undergoing testosterone therapy may face other potential issues such as gynecomastia, testicular shrinkage, hypertension, coagulation, and increased blood density. These issues are closely monitored by urologists to prevent any complications. Ultimately, the main goal of testosterone replacement therapy is to improve the patient's quality of life. As I said, we experience this every day in our clinic. 2 75-year-old patients come one by one. While one of them enjoys life enormously and lives enthusiastically, the other just stays at home, lives with extra illnesses, takes a handful of medicines a day, and tries to survive with them. Both patients actually live, but one lives happily and the other unhappily. Therefore, the focus of testosterone therapy is to enhance the patient's quality of life. Thanks for listening. Best regards.